We'll start with the second case. Geeta, you can present the case.
Yes, sir. This child is a 1-year-old female child.
Yeah, go ahead.
Present age is not 1 year, sir. 1-year-old female child with developmental delay and had neonatal storm and neonatal course in the form of cried immediately after the birth, but required some because of the respiratory issues and all. Child was admitted for 2 days. On day 23rd day of life, child started having refractory right side focal seizures with tonic posturing and right eye blinking. Almost required multiple medications and required 13 days of NICU stay for that, and also had Klebsiella sepsis positive. So child presented to us, child had a chief complaint was a developmental delay. So there is more cognitive delay than the motor delay. And presently the child is seizure free, but there is no eye contact, no response to the commands. And language wise, only babbling is present. And examination wise, AF is closed. There are some Kefale macules on the left leg, and DTR are breast with the metopic suture ridging and mild dysmorphic features like epicanthal folds, and also hypertelorism is present. We just want to know, our question is like whether it is any post-infectious brain insult which has happened or any genetic etiology underlying.
No organomegaly, nothing.
No organomegaly, sir.
Okay. The scans at what age? Any idea?
It is at the age of almost 1 year, sir.
Okay. So we have the T2-weighted sequences on the top, and you can appreciate that there is some degree of reduction in volume in the supratental brain parenchyma. Some white matter changes in the posterior parietal regions. Encephalomalacia with gliosis is demonstrated in the bilateral temporal lobes, more on the right in comparison to the left. The posterior fossa structures are relatively spared. Again, you can appreciate the cystic encephalomalacia in the temporal lobe on the FAIR sequences. Sagittal and coronal again demonstrate similar changes in the bilateral temporal lobes, right more than left. Corpus callosum is relatively okay, maybe slightly reduced, but not very significantly. Brainstem and cerebellar structures demonstrate normal appearance. On the SWA sequences, you can appreciate there's multiple tiny, predominantly peripherally located areas of blooming in the bilateral cerebral hemispheres, which corresponds to calcification on the CT scans. So there are multiple predominant subcortical cortical regions. Some degree of is also there in the corpus callosum. But yeah, so the primary predominant region is the subcortical and cortical regions, with changes of cystic encephalomalacia in the bilateral temporal lobes, and some degree of supratentorial volume loss with bilateral changes in the bilateral posterior parietal regions. Based on these imaging findings, if we review the article on the technical classifications, I would think of likely torch infections as one of the likely possibilities. But the only thing is the temporal lobe changes are not commonly seen in at least the common torch infections such as CMV and toxoplasmosis, but can be seen in HSV. Again, in HSV, the calcifications are slightly atypical. They usually don't present with such diffuse calcification in the bilateral cerebral hemispheres. Could not appreciate any other findings result because is to suggest a genetic etiology. Could only think of COL4A1 mutation, but they do not present with cystic encephalomalacia. They usually have shyelencephaly and some degree of porencephaly associated with it. So I'm thinking of acquired etiology, antenatal insult, likely torch, but cannot point out to which torch infection it is. At this moment, I'll open the case for further discussion.
The history was very classical for a perinatal insult, but the pattern of classification, the calcification which was there, was not usually what we see with the dystrophic calcification for injured brain. So that is why we're looking at any other possibilities apart from intrauterine infections we need to look at. And the course of the child is also static, very likely a single point insult.
Okay.
It's not progressively worsening. Handles beyond this sort of for a particular infection neonatal, or it can happen with any of the other perinatal infections which are not your classical viral infections which happen in the intrauterine period?
Are you talking about bacterial or the other non-viral infections?
Yeah, the bacterial or any other perinatal infections.
I'm not aware. I haven't seen an antenatal insult, bacterial infection. Calcification we usually see in only the viral, the antenatal or the neonatal viral infections, as far as I'm concerned. I'm not sure if others have any experience with the other infections causing such widespread calcification and encephalomyelitic changes.
Just to say that I support Nihaal's view that this is an acquired situation and very unlikely a genetic underlying disease. The temporal lobe did remind me also of herpes encephalitis, although the calcification is somehow unusual.
I would agree with that. I mean, herpes is within the torch infections, so calcification is possible.
Yeah.
In the neonatal period, you can get HSV too, although doesn't specifically affect the temporal lobes. So that could be still a possibility that sort of neonatal herpes and stormy course and then having this.
Just a word about the prognosis. I mean, if you have bilateral temporal lobe and hippocampal lesion, the prognosis for cognition and speech is limited.
Significant short-term memory issues as well.
Yeah. Okay, all right. Thanks for this question. I think I can say Dr. Vivek there, so I'll go back to the first case. Yeah, Dr. Vivek.
So, sorry I was late.
No problem.
So this is a 7-month-old baby who I had seen recently in the outpatient department, and they just came with the baby having significant delay. So, you know, the typical significant global delay, a bit autistic. We cannot say autistic at 7 months, but, you know, no visual connect, even though, and was in more in his own world. Behavior stereotypies had started with central hypotonia and reflexes were preserved. He had a normal CPK, perinatal period was uneventful. His BERA did show asymmetric hearing impairment, and subsequent MRI images made us just wonder what could be the differential diagnosis. Would you want to show them here?
Yeah. So this is the MR at 7 months of age on top of the T2 axials. We have some degree of delayed myelination in the white matter, the periventricular regions. Some hypointensity of the bilateral caudate nuclei, possible partialing. But the major changes are there in the posterior fossa. The brainstem is abnormal. There is slight clefting, dorsal and ventral clefting. The vermis and the cerebellar hemispheres are dysplastic, and they are associated with the subcortical cortical cysts, multiple cysts on both sides. On the sagittal images, you can appreciate again the brainstem is dysmorphic. There is hypoplasia of the cerebellum. Corpus callosum is relatively normal. No calcification or hemorrhage on the SWI sequences. So we have changes of cerebellar dysplasia with cortical cerebellar cysts, brainstem dysmorphia, and some degree of white matter abnormalities in the supratemporal brain parenchyma. If we focus on the cerebellar cysts, these are the differentials, common differentials for cerebellar cysts: muscular dystrophies, Polative Bolthauser syndrome, and the ADGRG1 mutation. In the muscular dystrophies, you have typically the kink-shaped brainstem, but not always. They can also be associated with supratentorial malformations. Polative Bolthauser syndrome, the brainstem is usually normal in appearance. There is no kinking or no clefting, and there are no supratentorial malformations. ADGRG has cobblestone malformations associated with the posterior fossa findings. Again, so differentials of cerebellar dysplasias with cysts, we have again these three common differentials. I'll not go into detail of the findings of muscular dystrophies. The only thing was the creatine kinase was normal, and if I would like to ask the clinicians if it can be normal in the alpha dystroglycanopathies as demonstrated in this paper. It is said to be elevated, but can be rarely normal. The normal genes do not demonstrate the cerebellar cysts and cerebellar dysplasia, at least on the imaging findings. This a few slides from the ASNR presentation from Dr. Poreti on the Poreti-Bolthauser syndrome. They commonly present with ataxia, oculomotor apraxia, cognitive impairment, and speech and language delay. On the imaging findings, cerebellar cysts are common, cerebellar dysplasia is there, there is ventricular enlargement, and the square-shaped ventricle is seen. So this is a typical example of the Poreti-Bolthauser syndrome. We have this square-shaped fourth ventricle with cerebellar cysts and cerebellar dysplasia, but characteristically, the supratentorial brain demonstrates normal appearance, and also the brainstem also demonstrates relatively normal morphology. So thinking of muscular dystrophies as the primary the first differentials, followed by these other common other differentials for this. And I'll open the case for further discussion.
So with the muscular dystrophy, so clinically, so what I have seen along with the hypotonia, knee jerks are usually absent, even though ankle jerks will be preserved. So more of a proximal weakness. So when I see a baby who has MRI showing cobblestone lissencephaly with dysmyelination, not hypomyelination, dysmyelination in the centrum semiovale with cerebellar and brainstem changes, and if the knee jerks are present, so they are like well elicited. So congenital muscular dystrophy for me as a clinician goes down the list, but I still do a CPK. So I have two things which are odd, and usually CPK, at least the patients I've seen, is high, slightly high. And so it's somewhere between 500 to 1,500, sometimes 5, 10, 6,000. So it's high. So when I have a normal CPK reflexes, knee jerks preserved, for me, sort of it rules it out. So, but again, there could be variations of the pathology.
I think genetics will give you the result very likely. I would not be surprised if CK can be normal at times. In terms of hierarchy, I would not put too much emphasis on a single present or absent jerk. This is not criticizing, it's just thinking.
Right. And the in congenital muscular dystrophy, you often, again, the patients I've seen supratentorial cortical malformation and dysmyelination rather than hypomyelination. Is that something? And ventricle being prominent, especially colpocephaly, corpus callosal posteriorly being dysgenetic, large head, often large head. So is that something?
Deficient congenital muscular dystrophy. I think this is more of alpha dystroglycanopathy, what we are talking about.
Yeah.
Isn't it, Nihaal?
Yeah, that's fine.
So alpha dystroglycanopathy, Lokesh, would they have normal CPK? So the merosin deficient?
One case we have a very low CPK. Yeah, merosin not merosin deficient,
Positive.
alpha dystroglycanopathy.
Alpha dystroglycanopathy.
That child had a very, positive. As alpha dystroglycanopathy. Yeah.
Yeah, yeah. So in that patient, did you have
somewhere around 300 plus?
300 plus is also a bit abnormal.
Not much.
You know. So, and did you have supratentorial changes? Like, did you have a degree
in the supratentorial region?
Yeah, dysmyelination or malformation. But this one doesn't have that.
Not there. Yeah. I think along something along that.
The other two possibilities are some, more to look for rather than for me as much as the muscular dystrophy.
Perhaps one comment that could be useful, that not always we see this cyst in the cerebellum in the context of Lama 2. Sometimes you can see without the cyst, and the diagnosis starts to be not so simple. But I normally the case that I've seen, they all still have this pattern of mild thickness of the superior cerebral peduncles, giving some mild form of Chaubert. So the DTI could be useful because in this case, even if you see the pattern of the superior cerebral peduncle mildly thick and horizontalized, they still have the differentiation of the superior cerebral peduncle. So you still see the head dot there.
Okay, so you probably go ahead with the genetics, Dr. Vivek?
Yeah.
Sure.
Nihal, there is a comment
Yeah.
on the second patient, just the second
Sure.
patient, you know. So you know, the subcortical, so the calcifications are subcortical in the second patient. So what we have also seen sometimes, you know, some form of so the infection causes a neonatal vasculitis. And if the vasculitis partially treated or it's difficult to treat with our antibiotic or whatever, if it's a HSV, so it leaves calcification sometimes. So we have patients with ventriculitis where we raised our hands. We couldn't treat it properly because the antibiotic won't go into the CSF. So those patients, when you do an MRI at 1.5 to 2 years age, they might have calcifications around the ventricle. And this is very, you know, this is very subcortical, isn't it? At the junction of the cord. So very vasculitis remnant, which leads to the calcification. So some form of an infection in the neonatal period, which got which was probably incompletely treated, or we just couldn't treat it fully, and left this sequelae of calcification later on.
Okay. Thank you. Okay, we'll move on to our next case. Dr. Ramya, if you're there.
Yeah.
Sure.
So this is a 4-month child who got admitted at just after completion of 2 months elsewhere with 2 days history of fever and had loose stools, vomitings, and then when the child was taken to hospital, the child was gasping. So they had to intubate the child, and child had multi-organ dysfunction, very stormy course. Almost took 15 days for him to come out of ventilator. Had very high CRPs, hyperkalemia for which they had to do peritoneal dialysis, very severe metabolic acidosis 6.8, and severe pulmonary artery hypertension. So because of the severe PAH, and they have treated with thiamine as well. They had to give INO and then sildenafil, bosentan. So after all this, the child settled, and then the child was out of ventilator. So initially, because of this stormy course, they were suspecting metabolic causes as well because of high anion gap. And the highest recorded lactate was 14, but then eventually it came down to normal, this one value. And then had one episode at presentation after probably 2 hours or 3 hours of admission, child had arrest, which required 1 minute of CPR. After that, he didn't have any errors, but then very labile PAH, for which they had to monitor him very carefully. So because of this, they were thinking of metabolic causes. They have sent TMS and urine GCMS, which were normal. And then TMS had elevated some amino acids, which was not correlating to anything. And then whole exome sequencing and mitochondrial also they have sent, in which there were no pathogenic variants detected. So, but they couldn't do LP and then MRI because of the condition. And child also had 2-3 episodes of seizures, which were easily controlled. And then the MRI. So we got an MRI done here after 25 days of the illness.
Okay. Of the second illness, you mean? The acute life-threatening event. After the acute life-threatening event.
Yeah.
Okay. Anything in the face? Any dysmorphism or just?
No, nothing.
Okay, sure. Okay, so these are the MR images. We have the diffusion. There were no acute or subacute changes to demonstrate any restricted diffusion. But as you can appreciate that there is bilateral subdural collections more on the left cerebral convexity. Also gliosis and some cystic encephalomalacia in the bilateral anterior and posterior periventricular regions. At least the subdural collection demonstrates mixed intensities. There's also another collection internal to the brain, brain over here. Cystic encephalomalacia again on the bilateral periventricular regions and posterior periventricular region. Some degree of hemorrhage or laminar necrosis in the occipital lobes. SWI, there was some small subdural hematoma along the falx. This subdural collection demonstrated blooming. The others did not demonstrate any blooming on the SWI sequences. Some hemorrhagic or areas of ischemic necrosis in the bilateral occipital regions. The degree of volume loss with, again, you can appreciate the chronic insult in the bilateral periventricular regions. The subdural collections, again, you can appreciate they slightly loculated in appearance. So there's overall reduction in the cerebral brain volume with gliosis and encephalomalacia in the periventricular regions, bilateral subdural collections or hygromas with subdural hematomas. We initially thought of to just rule out any accidental injury, non-accidental injury. I think eye examination was normal. Sepsis-related changes, hemorrhage can be seen, but the subdural collection is slightly atypical. If the child presented with initial infection, which developed later on into subdural collections and now hygroma, that can be a possible theory. And the acute life-threatening event can demonstrate the periventricular gliotic or ischemic changes. At this point, I'll open the case for further discussion.
The trigger for genetic testing in this situation?
Sir, because of they couldn't control the acidosis well, which was not explained by sepsis alone. Child was treated at Vijayawada Ankara, so I spoke to doctor there. So that was their main concern that time. They had to do peritoneal dialysis for, for the hyperkalemia part also. Mainly for that, they have done almost for a week's time.
Function, if you're hyperkalemic, acidotic, which is very likely secondary to some perinatal insult potential.
You mean infective, secondary to infective, sir?
Hypotension.
Hypotension, okay, yeah.
To kidney injury and then related, because these brain changes are predominantly acquired. There are nothing to suggest in genetic as well. And acidosis, as such, until we have some metabolic markers, very less likely that you will hit something on the genetics.
Can I ask what was the age?
Sorry?
What was the age at presentation? Sorry, I missed that.
2 months.
And why have we completely discounted the possibility of abusive head trauma here?
No, we had a doubt after the MRI. So we got an eye examination done. That was normal. And I also got PT-APTT done to look for any coagulopathies. That also turned out to be normal. And
that means the subdurals are unexplained. I think retinal hemorrhages need not last beyond 24 hours anyways. So you haven't excluded that possibility.
Yes, sir, I have taken history about how their, so when I was with the child was crying. So the mother started soothing the child very vigorously. So I asked, so how was the child treated at home? And then she told me her grandmother is taking care of the child, the child's grandmother. They also have a habit of shaking the child so that the child would sleep, because the child had excessive crying after the discharge. So I don't know if that could be a contributing cause. That is the only history I got.
The fact that they are telling that they have been shaking this child,
No, they didn't come out, sir. No, they didn't. So when I have seen, she was doing that in front of me. So I have asked, so how do you, why don't do it so vigorously? Then I told, and then I asked them.
Was the skeletal survey done, Rami?
Skeletal survey, no, they were not very much willing. But then on examination, I couldn't find any tenderness points, nothing like that. Yeah.
Dr. Mankad, would you suggest a skeletal survey?
I think absolutely this child basically needs a CT as well to exclude any evidence of fracture, needs a spine for subdurals as well as a skeletal survey. The fact that you saw the carers shaking the baby in a particular way enough to ask them, why are you so vigorous? I think that's a pretty bad sign in the clinic.
No, sir, they were doing it unknowingly. It is not like knowingly they were doing it.
Yeah, no.
So it's their way of soothing the child.
Usually it's unknowing that the child is crying and they try to basically calm them down. I think this differential has not been taken away from this case. And with so much brain injury, when you then pick up metabolic acidosis later on, that's not a surprise, is it?
This was done pretty later into the illness, 25 days after the illness.
Exactly. That's the point. That means it was acutely ischemic tissue at that point in time.
Whether there was a significant brain atrophy and the subdurals are secondary to the brain atrophy?
No, but why should there be brain atrophy in the first place?
No, because there was a
injury.
insult. Injury is there. Hypoxia is very much significant. Child required CPR. Hypotension was very persistent.
Yeah, but in usually hypoxia, we usually don't get subdurals. I mean, they can be atrophy, but not such significant as subdurals is what I think.
No, sir, Lokesh sir, even I had that one possibility in mind, whether because of that shrinkage of the brain, whether the child had secondary.
Yeah,
but I could get literature on hygromas only.
Yeah, but if you see only predominantly the periventricular regions are involved. I would expect more widespread injury of the cortex of the entire cerebral hemispheres for it to shrink down and then cause the subdurals.
Nihaal, have we time to go back to the history, to the text slide?
Yeah.
I mean, this child was severely ill, had multi-organ dysfunction, had sepsis and so on, and probably also hypoperfusion. And I think although any subdural is suspicious of abuse, for me, this is down on the list. This is primarily a severe illness, probably associated with perfusion, leading to atrophy, and the shrinking of the brain results in secondary extracerebral fluid collection. This is, for me, a secondary and not the primary event.
What we commonly see in glutaric acidurias, where we get subdurals after brain atrophy and injuries, acute insults.
Yeah, it is there, but the Sylvian fissures and the basal ganglia are relatively straight, so that would be fairly difficult.
That would be picked up on exome also.
Yeah.
That was not there. Yeah.
That it is GA, but that's where there also you don't have injury, non-accidental injury, but you still get those subdurals.
These are usually of uniform intensity. You don't get multiloculated, separated kind of a thing. Okay.
Okay, I'll give a follow-up of the child.
Yeah. Thank you. Just a few comments. Multi-organ dysfunction from sepsis with poor brain perfusion and insult can result in shrinkage. This is from Riyaz said. Mitochondrial genomic abnormality. I think the panel did not pick up anything. So, yeah. If possible, we can get a skeletal survey. Ramya?
Yeah, I'll get it.
Just to read out. Okay. Yeah. Thanks.
Okay. Thank you.
The next case is from Dr. Nikhil. Thank you. Dr. Nikhil, if you're there, you can go on with the case.
Yeah, this is a 3-day-old preterm, borderline preterm, 35-weeker, born to non-consanguineous parents. And initially, immediate parental, there were no specific concerns, except that he developed seizures towards almost end of the day. and followed by, and also had developed respiratory distress, for which he was admitted in one of the district general hospitals and then referred. And if I remember correctly, it was day 2, day 3. He was referred. On examination, the head circumference was 32, and there was a sutural ridging, which probably indicates that there was already, I mean, when we saw the baby, it was day 4 of life. So supposedly indicating there is already some brain volume loss. Baby had subtle dysmorphic features, some retrognathia, which wasn't, I wouldn't give too much significance to that, and suitable by dysfunction. Baby was very drowsy, had a poor neonatal reflexes, and increased tone in bilateral upper limb. And there were already hamstring contractures. So something long-standing. This, I mean, overall examination findings were predominantly suggestive of something going wrong antenatally because of sutural ridging and hamstring contractures, which were already there. But as such, there was no significant immediate perinatal history to suggest these signs and symptoms. And then I think we did a scan on day 5 of life.
Okay. So yeah, day 5 MRI on top of the T2 axials. There are bilateral paraventricular cysts, subependymal cysts along the frontal horns. The gyri, though the gestation age corrected is around 36 weeks, slightly simplified in the frontal and the temporo-occipital regions. If you see, the white matter is also demonstrating slightly swollen appearance, predominantly in the subcortical regions, which on the corresponding fair images, we have this rarefied appearance of the white matter. There are some subcortical aerial rarefaction or subcortical cyst-like formations in the frontoparietal regions, also the anterior temporal poles. Posterior fossa structures are relatively spared. Cerebellum is normal. Coming to the T1s, on the T1s in the base, at the level of the basal ganglia and thalami, we had this hyperintensities in the ventrolateral thalami and also in the posterior putamen and lobus pallidus, and also these hyperintensities in the dorsal aspect of the midbrain. On diffusion, the cortex appears slightly bright with corresponding low signal changes. Other than that, in the deep brain nuclei and the white matter, there are no abnormalities on the diffusion, no hemorrhage or calcification on the SWA sequences. Based on the imaging findings, if we look into the subependymal cysts, these are the various differentials ranging from the metabolic genetic disorders to acquired conditions such as hypoxia, ischemia. This reminded us of a discussion which we had previously with Dr. Bolthauser of the antenatal insult, hypoxic insult resulting in these bright thalamic changes on both sides, predominantly thalami, but also can involve the subthalamic regions and the basal ganglia. But I found that the white matter changes, the refractory changes, may not be typically seen in only hypoxic ischemic changes, insult. So these are the differentials for the temporal lobe changes, Aicardi Guterres, CMV, rubella, mitochondrial Van den disease, and vanishing white matter. So vanishing white matter, again, these are differentials. They can also present with these paraventricular cysts or subependymal cysts. And we have previously seen an infant with these refractory changes in the white matter with a genetic diagnosis of vanishing white matter. This was from Dr. Vivek. Aicardi Guterres can also have these refractory swollen appearance of the white matter. So all in all, the only thing is it a genetic insult or is it acquired insult, or is it a two-hit theory? I mean, so at this moment, I'll open the case for further discussion.
Just a quick thing. After we discussed this scan, Dr. Nihaal, we went back and took a history. There were a couple of weeks back, mother had sustained abdominal injury. I mean, she had suffered a traumatic injury where she fell down and she had sustained a femoral fracture actually. So supposedly looks like a significant kind of trauma. But that was a couple of weeks back and they had done this Doppler and other studies by then. Those are all normal. So baby was supposedly fine, but that was the only significant antenatal insult, if at all, that would have happened.
Okay.
May I add, did the mother mention reduced fetal movements for a certain time?
No.
This
so
is a common...
no reduced. Nothing was reported by mother, and they immediately took her to the hospital where the ultrasound and the Doppler studies were done to look for. So everything was fine as far as baby is concerned.
Is the child microcephalic, Dr. Nikhil?
Sorry. Yeah. So 32 for a, 32 for a 32 centimeters for a 36-week old child will be lower border of normal.
Okay.
Can I add? I agree with your comment that the history and the findings are very likely suggesting a prenatal event. And I think, Nihaal, on the list of the subendymal cysts, you should add transient normal finding. There are patients who have cysts which disappear in a few weeks. So this is not necessarily causative.
The rare factory changes again, cystic, the subcortical cystic changes, that will also be seen in a prenatal insult, acquired insult.
It seems to be less likely conatal cysts, but more for genolytic cysts. And there are some findings that are concerned for ischemic injury, but more pronounced than expected. One thing that is nice to remember for mitochondrial disorders in neonates, they have a very different pattern of presentation, as you mentioned. So we don't expect like hemorrhage or cysts in the concept of primary mitochondrial disorders after the first months of life, if the injury starts after months of life. But in a very early onset or even in the prenatal period, they may have a completely different presentation, including hemorrhage, cysts, and along with lesions that may resemble lesions related to hypoxemic injury. So I'm not sure that's the pattern that we should still consider for mitochondrial, but I would keep it in differentials.
All right. Thanks, Giza.
Okay, so investigations wise, this baby, I think we also considered a possibility of molybdenum cofactor here. Is that right, Dr. Nihaal?
Yeah.
Because of that sort of white matter and cystic pattern.
Yeah.
So homocysteine, we did investigate a bit, but we couldn't investigate much because of financial constraints here. So homocysteine, uric acid, both of them were normal. Very long chain fatty acids were normal for this child. And again, because of financial constraint, this baby was taken to other hospital. And unfortunately, this baby has died a couple of days back. And we do not have any clear reason. This baby was on ventilator, never had any further seizures as such. So some of the possibilities like paradox-independent epilepsy and all those things can be at least clinically ruled out. But the only thing on retrospect, what I was thinking is normally when we see late infantile presentations of vanishing white matter disorder, common triggers are fever and trauma. Whether the similar thing would have happened here, where the maternal or the abdominal trauma to mother would have triggered the event, and that is why baby presented at quite early neonatal age. I'm not sure whether that anybody has encountered that sort of phenomena before.
I remember Dr. Lokesh had a case of vanishing white matter with subependymal cysts. I don't know if he remembers it or not. Many months back.
You remember better.
Okay. So,
I mean, we still have a blood spot sample with us, which we thought once. So father came couple of days back, but unfortunately I was not there in the hospital, so I'm so not sure. So I'm going to call father tomorrow, and then we'll try and proceed with the genetics.
Okay.
Sure. Thank you.
All right. Thank you. The next case again, Dr. Nikhil.
Yeah, so this is again very interesting. Very, very extremely poor family, came from a very financially backward kind of situation. So she's 10 years, but this was the first time they had taken her to medical attention. She was developmentally normal until 4 years of age. And that age, she had a very high grade fever, but no encephalopathy at that time. And following which they started noticing that there is a progressive walking difficulty, which has progressed over a period of next 2 years, and later after that she hasn't progressed until sort of next 4-5 years. She's kind of following a static course. So there was a 1-point insult following which there was a regression and then followed by a static course. Child is not going to school, so it is very difficult just based on the history to assess intellectually, but overall is giving a feel of having borderline intellectual disability. And on examination, she had a spastic paraparesis and bilateral pyramidal signs in lower limbs and upper limbs. With normal head circumference, other cranial nerve examination was normal, no cerebellar signs here. So clinical possibility and no family history of any similar illness, nothing antenatally to this child. So considered possibilities were hereditary spastic paraparesis, but there was no inheritance pattern demonstrated here. And of course, mitochondrial was also because there was a 1-point regression here.
Yeah. Scan done at 10 years? Okay.
Sorry?
The scan is done at 10 years? The age of scan?
So I didn't.
The age of the child
age of scan is 10 years.
Okay. Okay. So we
years.
have.
This is just last month. Yeah.
Okay. So again, we have hyperintensities in the bilateral frontal subcortical regions, also along the outer aspect of the genu of the corpus callosum, but predominant changes are in the bilateral striatal regions, demonstrating reduced volume and these hyperintense changes. Some tiny focus in the left cerebral peduncle and also in the dorsal midbrain tegmentum. No cortical malformations, no other white matter abnormalities. Thalami are relatively spared. Diffusion, there are tiny foci of restricted diffusion in the bilateral caudate. The frontal white matter changes demonstrate facilitated diffusion. Here again, you can appreciate these bilateral striatal necrotic changes with the periventricular, anterior periventricular white matter changes and also the involvement of the brainstem midbrain tegmentum. SWA, there was mineralization of the global paradigm for a 10-year-old, maybe age appropriate or slightly increased. Corpus callosum involvement can be demonstrated in the anterior segments on the sagittal images. Based on the imaging findings alone, these are the various differentials to be considered. Given that this is a progressive etiology with a single point regression, more of a genetic disorder than a post-infectious or post-hypoxic insult. Mitochondrial disorders are in the differentials. Glutaric aciduria is unlikely. Huntington's disease also is unlikely. Interferonopathies can be possible. The basal ganglia imaging phenotypes. Mineralizing angiopathy is unlikely. We discussed previously with Dr. Vivek, he had a patient with similar changes, but the child had chorea of PDE10A mutation. Anti-E2R antibodies and biotin thymine also unlikely. So we're moving towards mitochondrial disorders, interferonopathies as a possible differentials for this case. At this moment, I'll open the case for further discussion. Spectroscopy wasn't done, just in case that's a question.
I like the hypothesis of other one. I think it's a good differential interferopathies with basal ganglia involvement and white matter chains like this could be, of course, it's clinically compatible. Other one would be a good differential to include.
Yeah. Can I ask you questions?
Yes, Ian.
First of all, at the age of 4, I mean, do we have any history on how the symptom was there an intercurrent illness? Did you have a massive? I mean, I know it's a long time ago, but I mean, I totally agree with you that there's really only 2 differential here: the mitochondrial and the interferonopathy, and sometime a bit of the history may help, and also other organ involvement or any there were. Actually, with if it's bilateral striatal necrosis, it's probably most likely to be ADA1, and actually they don't really have other organ involvement in this particular type of interferonopathy. But with mitochondrial, I don't know if there's anything in the eye, anything that we can do cheaply, eye, heart, or anything like this to look at. And the history at age 4, that was the first question.
I haven't done any further investigations as such at this moment. But yeah, it might be worth doing an ophthalmology and nerve conduction. Possibly we could have done just to get other corroborative evidences in favor of mitochondrial, maybe.
And from the history, like even from the age of 4 to 10, has it been like a subacute progression? Has it been, you know, one?
So she kind of had followed a progressive course from 4 years to 6 and 7 6 years 7 years sort of age, and following that she has predominantly remained static.
Okay. And has a bilateral pyramidal, but is she? I mean, is she mobile, or what is she? How is she clinically?
Yeah, she is able to walk on her own with some minimal support. No proximal muscle weakness. She's kind of mobile with minimal support.
And speech?
Speech is also spastic.
Okay, but cognitively she's okay?
Cognitively appears to be mild intellectual delay, but it is very difficult to assess. I mean, she has never gone to school as such. So she's able to answer simple things, but formal IQ assessment has never been done.
And the head circumference?
Head circumference is normal.
Okay, because I think, I mean, maybe other people know more than me with the interferonopathy, it's more likely to be low, no?
Yeah.
Or that with some of these interferonopathy, I don't know if with this particular type, because, you know, the treatment seemed to work more with the one with a kind of systemic inflammation. I don't know whether there's any kind of implication to this. What your feeling is that it's more likely to be mitochondrial?
Well, with that sort of history of 1-point regression and previously being normal, when many of the interferonopathies probably, I mean, they would be symptomatic much earlier, if I'm not wrong.
Yeah.
I mean,
Yeah.
Yeah. Okay.
Okay, thank you.
Sure. Thank you.
Next question, Dr. Srikanth. Dr. Srikanth, if you're there, you can present the case. Yeah.
Good evening. So here we have a 1-year child, like a development normal child, presented with motor regression since last 10 days. Normal development, no perinatal issues, non-consanguineous marriage. For elder sibling is 5 years, he is healthy. This baby is the second child. Till 1 year, child was fine. Last 10 days, they noticed excessive cry and irritability, followed by motor regression. Like child was able to cruise and walk 1 or 2 steps, stopped walking, stopped sitting, always crying a lot, asking the parents to carry. Past 10 days. This is and the basic blood. When the on presentation, child has mild spasticity of right upper limb, truncal hypotonia. Other domains of development were normal. Vision, hearing is normal, swallowing is fine. Child is recognizing the parents. So this was a brief presentation.
Okay, right. Thank you. We'll move on to the MR images. On the MRI, we have these periventricular confluent abnormalities, also involving the deep white matter in the bilateral cerebral hemispheres, involving the corpus callosum, a handlebar-like appearance of the dorsal pons. On FLAIR, again, symmetrical confluent hyperintensities, no rarefaction or cystic age changes within the white matter changes. No structural malformations. Diffusion, there are some areas of restricted diffusion in the deep white matter and also the areas of involving the corpus callosum. On sagittal images, the important aspect is the middle blade of the corpus callosum is predominantly involved with relative sparing of the inner and outer blades. Again, sagittal images, you can appreciate the involvement of the ventral pons. Spectroscopy is apologies for slightly pixelated images. We had a lactate peak and there was also a peak at 2.4, a significantly large peak at 2.4, which is attributed to succinate. So based on that, on the MR images, we thought of a probable diagnosis of succinate dehydrogenase deficiency. This is a companion case from Belgaum. I don't know if Dr. Compton remembers the case. Again, symmetrical confluent white matter changes with the succinate peak at 2.4. Just a note on the SDH abnormalities. They can present with confluent white matter abnormalities, but also develop into cystic refractory changes, and they can demonstrate restricted diffusion. Spinal cord involvement can also be seen in the form of long segment involvement. Cerebellar abnormalities involving the white matter can also be seen, involving the middle cerebral peduncles. Brainstem involvement is variable. So overall, based on the imaging appearance alone, a possibility of succinate dehydrogenase deficiency is considered, and I'll open the case for further discussion.
So here one more, this child we started on mitochondrial cofactors. Over a period of 3 days, child's sensorium was better, irritability has come down. Motor part is the same, like still truncal hypotonia is there. Weight bearing is improved by a little, partial weight bearing is there. So only thing is, in such situations, genetic report will take 2 months, at least 45 days to come.
Yeah.
Concern is, in this situation, we have lost 2 or 3 kids, similar presentation of like, if we consider like infantile leaks variant, they may initially have a upper brainstem involvement, but within a span of say next 1 month or 2 months, they are having some sort of lower brainstem involvement, respiratory failure, and sudden death.
Yeah.
So some kids are even not coming back. We can neither keep them for 2 to 3 months in the hospital. If we discharge them on cofactors, we are losing some kids. Means they are having another episode of regression. This time it will be more of a lower brainstem involvement, respiratory failure.
Yeah.
So is there any pattern to follow brainstem involvement? Like here it is, initial presentation is predominantly mid-pons.
Yeah.
So how likely it's going to progress to the medulla? How much time do we have in such situations? The rate of reversal progression.
I will redirect that question to Caesar if he wants to take that up.
So that
or any of the panelists.
So in basically the brainstem pattern, I want to understand like brainstem pattern of infantile leaks, the rate of progression. How much time do they give to us? Do they give, usually studies say they give some progress over 5 to 6 months, some may give longer time. But I have seen cases who have progressed even lesser time. Within a span of 1 to 2 months only, they are progressing to respiratory failure.
Okay. Anyone wants to take up that question? I'm not clear of the time frame of progression.
It's a 10 days. It's over a period of 10 days.
No. That's your question.
Yeah.
The brainstem spread.
Spread, yeah. From upper brainstem to lower brainstem. Like question, maybe we can confine to infantile leaks variant of brainstem.
No, I don't have any answers, and I think none of the panelists also have any answers. Again, do you want to take it? Any experience? Okay. Is this been sent for genetics, Dr. Sika?
Yeah, it was sent. It will take 45 days to them. It was just sent 15 days back. So maybe it will take another 1 month for the results to come.
Okay, sure. Okay, right. Thank you.
Yeah, thank you.
Next set of cases are from Dr. Kamte. Dr. Kamte or the fellow Tanuja, if they want to take up the case.
This is Advait, who is a 10-year-old male child who was normal till 3.5 years of age, and then developed gradual onset of weakness in right upper limb, followed by weakness in the right lower limb 3 days later. There is no history of fever or altered sensorium. On examination, child had right hemiparesis, and CSF analysis was normal. Suspecting autoimmune encephalitis, we started steroids and physiotherapy. And first MRI was done, which showed prominent sulci in the left frontal region. After 6 weeks, we stopped steroids because MOG and NMO were negative. Now child has right hemiparesis, hyperactivity, and poor scholastic performance. Since the last 6 months, child is having right upper limb chorea and dystonia. And suspecting MOG is equal if serum MOG was repeated at 6 years, which was also negative. And a repeat MRI brain was done, which will be shown next.
Yeah. These are the second set of MRIs, and you can appreciate that there is asymmetry in the volume of the bilateral cerebral hemispheres. You can appreciate that the sulcation pattern is prominent in the left frontal region, going up to the perisylvian region. There's also reduction in the particulospinal tract volume, some Wallerian degeneration along the particulospinal tracts involving the thalamus and the peritrigonal periventricular region, while reduction in the cerebral peduncle on the left side as compared to the right. So overall, a reduced volume of the left cerebral hemisphere with some areas of particulospinal tract Wallerian degeneration, no structural malformations. Posterior fossa structures are normal. On sides, the corpus callosum demonstrates normal thickness. Diffusion, no diffusion changes, at least no acute or subacute changes on diffusion. SWI, again, no significant abnormalities. The vascular pattern is symmetrical on both sides. There is no hyperperfusion, though not ideal, but at least on the SWI sequences, we cannot appreciate any asymmetry. Angio, again, cannot appreciate any paucity of vessels. No stenosis. Neck vessels also demonstrate normal appearance. The findings are predominant left side hemispheric atrophy. These are the differentials. I'm thinking of acquired cause, and these are the list of differentials to be considered. At this point, I'll open the case for further discussion.
Can you repeat, the MR was done at what age? Is that an actual MR or a follow-up?
This is the follow-up.
This is a follow-up.
And the interval is how long? I mean, this MR looks like long-standing residual change, which has nothing to do with its walking problem with onset 3 days ago. Maybe there is something superimposed, but this is a long-standing problem.
The first insult was at the age of 3.5 years of age, the first time. After that, child had residual right hemiparesis. For last 1 or 2 weeks, child has excessive abdominal movement now in the right upper and lower limb. And this scan is done after the gap of almost 6 years now. We want to know what would be the possible cause for this type of worsening which has happened now after almost a gap of 6 years. Now child has got predominant abdominal movement in the right upper and lower limb along with the weakness.
Is all the worsening in the movement still on the right side? Is all the worsening of the movement still affecting the right side of the body?
Yes, sir. Yeah, yes, Kish. It's on in the right upper and lower limb. Yeah, it's got more of mixture of chorea and dystonia.
And nothing, no skin finding. I mean, I feel from the history, it's much more likely to be Rasmussen's, I think, more than anything else. So oligoclonal band would be supportive of that. It doesn't sound like an autoimmune encephalitis, although we can see some without bands. But the other thing is sometimes you can get some like peribrombach scleroderma mimics, and if they get any skin pigmentation, it can be quite subtle underneath the hair. So it's maybe worth looking. They can present like.
Skin was normal.
But did you specifically look out underneath the hair? Because it's not something I would routinely do. I only do it because I'm just saying we had a few cases. I mean, I don't know, Kish may comment on the imaging. It's not typical, but you can get a hemiatrophy in the context of Perry-Romberg. And the skin pigmentation is definitely not as obvious as in the textbook. Sometimes it's just really subtle when you look underneath the hair follicle.
Okay, that I not seen. Maybe I'll follow up. I'll just try to look for it.
But according to your slide, the history started in the first year of life because the
3.5 years.
Lower limb problem since 3 years. So in the first year of life. And now we have something who is kind of disturbing the equilibrium. And I've seen patients with have some kind of mild hemicerebral palsy, and then they kind of deteriorate by whatever reason and get extrapyramidal signs. So for me, this is something very long-standing and not genetic or metabolic.
The first symptom was at the age of 3.5 years, first symptom 3.5 years. Now the child is 9-year-old now. So there's a gap of almost 6 years now. Child was normal before the age of 3.5 years.
Just a comment, Mika Shapira is saying, says that we recently had a similar case that progressed to contractile side. Consider immunotherapy responsive childhood neurodegeneration with systemic and central nervous system inflammation described as part of interferonopathy. Yes, she has reference to your paper in 2018 that immunotherapy responsive childhood neurodegeneration with systemic and CNS inflammation. Do you think it fits under the category?
It's difficult. I think this was like a cluster of 3 children that presented like this. And I always ask myself whether they were like a subtype of Rasmussen. Interestingly, they also had these abnormal LFTs. And so, I mean, to answer to your question, I think it's semantic because we didn't have a unifying diagnosis or genetic diagnosis. I think for this patient, the key thing is whether you try immunotherapy. So, I mean, I don't know. I think if there's any signs of, particularly if the bands are positive, or if there's anything to suggest that, I will probably do a trial. The really difficult thing, and we did it with those kids, is that we got a physiotherapist to do a pre and post IVIG, just because it's very difficult to know in growing, children, how much is really the treatment effect. So if you do try immunotherapy on this patient, I would encourage like setting some ways of measuring it.
Okay, fine.
But did we get what is the band? Did anybody tell me the oligoclonal bands?
We haven't done oligoclonal bands.
Okay. So I will probably do that, and I will also do stuff like neopterin, or if you can, just because really any signs of inflammation may help you kind of push maybe towards treatments. And if you see nothing, it's a bit tricky, because unless, then again, the radiologist will guide me. This could also be, I guess, although the history doesn't fit, like a perinatal. So like they can compare later on. I'm just saying, it's difficult to know what you're treating and what not. And of course, I don't know, is there a plan to repeat this MRI? If you would see maybe in a year time that there's progressive, hemiatrophy, then it would help with some of the differentials.
Okay, fine.
Yeah, I think the thalamic involvement is very unusual for Rasmussen's. It's a very strong thalamic involvement here.
And also the seizures. So clinically it's atypical, but I'm just trying to think what's the most likely cause.
Yes. Clinically, there are no seizures, and even the EEG done was normal. I had shown somewhat of slowing, but no different discharges. Clinically, no seizures.
I mean, yeah, no, I'm just trying to basically say that, with Rasmussen's, first of all, we have only one-time scan, and I think the basal ganglia is relatively preserved. The thalamus is a very strong feature here. You have to start thinking about all the other perinatal insults. The only problem is the sudden recent deterioration that I'm not able to put together. Is there something in the periaqueductal region, Nihaal, on that single slice that I can see?
I think that's partially the CSF.
Just partial voluming, okay.
Yeah.
So basically, see of any signs of either inflammation or progression, that may suggest treatment, and otherwise, I think it's very unlikely. It's likely to be as Kish said, a kind of a perinatal insult.
Yeah.
Thank you.
Okay. All right. Thank you. Next case again, Tanuja.
So this is a 6.5-month-old male child who's the firstborn to a non-consanguineously married couple, born via LSCS in view of non-progression of labor. Baby was admitted to NICU from day 3 of life for 16 days in view of respiratory distress. Child has delayed developmental milestones and hypotonia, and was now admitted for pneumonia and ventilated for poor respiratory efforts. On examination, DTRs were absent, and child succumbed after 2 weeks of admission. child also had facial weakness. The head circumference was 45 centimeter. And we'll have the MRI images now.
Okay. So MRI at 6.5 months, diffusion changes, extensive areas of restricted diffusion, predominantly in the deep and subcortical white matter, also involving the central white matter, the internal capsules. Going on to the brainstem, you can see the brainstem involvement, cerebral peduncles, the red nuclei, corresponding low signal changes, predominantly in the subcortical white matter and also in the central areas of the brain. T2 weighted sequences, you can again appreciate the T2 hyperintense changes in the central white matter, also subcortical, but slightly difficult to differentiate on a 6.5 month child. Brainstem changes, you have dorsal involvement of the pons, also involvement of the medulla, the pyramids, the decussation fibers, inferior cerebral peduncles. The sagittal images, again, the extent of the involvement of the medulla and some degree of hyperintensities in the spinal cord. Spectroscopy, because the corpus callosum also dysplastic, slightly abnormal in morphology. Spectroscopy, there was a lactate peak in the brainstem, slightly elevated cholines. The white matter again demonstrated elevated cholines, but no lactates, no significant lactate peak or any other diagnostic peaks. Based on the findings, thought of a possibility of mitochondrial disorder. The top panels are the images of the patient, and these are the abnormalities presenting with brainstem and cerebellar changes. NDFS1 can present with brainstem and cerebellar abnormalities. The medullary pyramids and decussation is typically seen, which is also seen in our case. They usually involve the lemnisci. It's not involved in our case. Cerebellar white matter is also involved. DAS2, the tRNA mutation disorders, that is the LVSL and HBSL. There is an absence of the trigeminal nerve involvement, which is characteristic of LVSL, though the medullary changes are commonly seen in our case. HBSL, again, there's also the absence of involvement of the superior cerebral peduncles, the medial lemnisci, which is not seen in our case, but again, the medullary changes are commonly seen in the index patient. These are again differentials of the LVSL variant, which can have restricted diffusion and supratentorial white matter and posterior fossa involvement. This is an example from Caesar. Again, we have similar involvement of the supratentorial white matter and also the brainstem and cerebellar changes with spinal cord involvement. Based on those are the differentials we considered, and I'll open the case for further discussion.
We got the genetic evaluation, mitochondrial and exome sequencing for the child, which showed TK2 exon 7 heterozygous mutation variant of unknown significance.
Okay, what does it belong to? Which group? Any idea?
Sir, should I tell about the disease OMIM? Is that what you're asking, sir?
TK2 exon 7.
TK2 exon 7.
You can read that.
Yes, sir. It's associated with progressive external ophthalmoplegia with mitochondrial DNA deletions.
So Kiran says, is that the gene for?
Mitochondrial DNA depletion syndrome 2, myopathic type.
Okay.
Only thing, it is a heterozygous mutation, whereas the condition is homozygous. So the other mutations are not seen. You send the sample for microRNA, waiting for the report.
Okay.
Hi, sorry, I'm the first one to join here. Can I just ask you what were the liver functions in this child, please?
It was normal, sir. I left it.
Thank you.
Do you have the glycine levels measurement?
Dr. Kamtek, was glycine tested? Cerebral glycine or?
I didn't get it.
Glycine. He's thinking of NKH?
No, we're not done TMS, but the exome was negative.
Okay. Yeah.
We done a clinical exome, which is negative.
Would you mind repeating the OMIM number?
Kaluja, you can put it in the chat if that's also okay.
Okay, sir.
All right, thank you. Go next case. Yeah, Chandra.
Hello. Hello, am I audible?
Yeah,
You're
audible.
Yeah, this is a 1 year, 9-month-old child, female child, born of a more than 3rd-degree consanguineous marriage, who was born at term with good birth weight, no perinatal insult, and was having came with complaints of global developmental delay, not attained any milestones, initially presented at 7 months of age. Then when reassessed now at 1 year, 9 months, this child is having only a social smile, which is very infrequent, and is having some cooing. There is a significant family history of a sibling who has died at 4 months of age, but the cause is not known and there was no perinatal insult and birth history was normal. On examination of this of our current patient, the child has had congenital nystagmus. There is central hypotonia. There is dystonia with dystonic tremors and hyperreflexia with ankle pronus. So based on the history and the examination, the differential diagnosis considered were of structural malformation, maybe a neurometabolic disorder such as organic acidemia, or a hypomyelinating leukodystrophy, which may be a PMD-like disease. And we went ahead with an MRI investigation.
Yeah, thank you. MRI, we have diffuse white matter changes for 1 year, 9 month hypomyelination. Okay. There is dysmorphic appearance of the lateral ventricles. Again, cortical malformation predominant in the left cerebral hemisphere. The posterior limb capsule also demonstrates its abnormal white matter changes. Posterior fossa structures, there is some, okay, the brain steps of this left cerebral peduncle is slightly reduced in volume. The bilateral cerebellar white matter demonstrates this confluent white matter changes. Corpus callosum is relatively normal, but again, you can appreciate the hypointensity that is involving the corpus callosum. Some areas of cystic degeneration in the cerebellar white matter and also in the periventricular regions, some areas of rarefaction. So cortical malformation, predominant on the left cerebral hemisphere, dysmorphic lateral ventricles, abnormal white matter changes confluently involving the supra and infratemporal brain parenchyma. On diffusion weighted sequences, you have this confluent area of restricted diffusion involving the deep and periventricular white matter extending up to the subcortical regions. The cerebellar white matter changes also demonstrate cavitatory appearance given the peripheral areas of restricted diffusion. This is the cut section of the cervical cord. Again, you have appearance of some area of restricted diffusion of the upper cervical cord, predominantly on the lateral and dorsal aspects. I had the diagnosis of the case, but the findings are pretty peculiar, atypical for this case. SWI, again, no abnormalities, and on spectroscopy, we had this large lactate peak. I think, if I'm not mistaken, Dr. Kamte, this was an ISCA2 mutation.
Yes, yeah.
So
This
the white
is
matter.
I'm sorry, it's a ISCA1 mutation.
Okay. So at least ISCA2, we have this conflict. The white matter changes are typical, which are seen in our case. The posterior fossa findings are also similar. It's the cord involvement, but malformation is not at least described until present. The mitochondrial disorders with malformations from the compendium book. These are the genetic genes which have typically shown to have malformations. PDH is the most common, but these are other genes which show malformation. So this is a first case, at least for me, and I'll open the case for the discussion if anyone has any similar experience with that mutation.
This case is incredible. We have collected some cases in the context of iron sulfur cluster Bergenius dysfunction. We have one about 57 3 weeks ago, with the same features that we're seeing here: malformation of the cortex, restricted diffusion of the white matter extending to the middle peduncles, with some areas of potential cavitations, also involving the posterior limbs of the internal capsules. All of these things with restricted diffusion and the potential malformation of the cortex. That's something that's not so commonly remembered in the context of mitochondrial having been seen mainly in the neonatal period and basically in the context of iron sulfur cluster Bergenius dysfunction. So even 57, we have one exactly the same, not exactly, but a very, very close pattern that we're seeing here. And ISCA2, as I said, is one of the differentials in the context of the Bergelius effect.
Thanks, Ida.
So this is an ISCA1, isn't it?
Yes.
Yeah.
Yeah, which would also be consistent with the imaging phenotype. I mean, there's not much known apart from the fact that it gives you multiple problems. The malformations is worth publishing. I don't know where this case is emerged from.
Yeah, I already discussed that, Dr.
And it's bilateral, I think, not just on the
Yeah.
limbs.
Okay, right. Thanks. Dr. Kamte and Caesar, I'll maybe you can publish
Fine.
both your cases.
Yeah, fine, surely.
Yeah, sure. Yeah. The next case is from Bhatia Japit. If Sahil is there, he can quickly.
Yes, sir.
Yeah.
So this child is a 9-month-old male child. He came with complaints of fever, diarrhea, and vomiting that he had since 6 days. And on the 7th day, he developed right hemiplegia. And after an hour, he had an episode of a seizure in form of deviation of mouth to right side, right focal seizures involving the right upper limb and lower limb. And he presented in status that time. So the admission is GCS was 15/15 with the tone in the right upper limb and lower limb was hypotonia with brisk reflexes and power of 1/5. The rest of the system examination was okay, left tone, power, and reflexes. So considering the possibility of stroke, and so he was loaded with Levera and phenobarbital and subsequently shifted to PIC for further management, where he was evaluated for stroke workup. So his SGOT was elevated, SGPT was also elevated, coming to investigation wise. LDH was elevated with a high D-dimer. And the other stroke workup, which was there, like sickling profile COVID, RT-PCR, homocysteine 2-depot, ANA, which was completely negative. So, first initially a CT scan was done, followed by an MRI. Yes, sir.
Yeah, you can go ahead. I'll show the images after.
Yeah, okay. After which we we saw that there was an edema which was there in the right lower limb, and we did a Doppler studies also. So it was suggestive of partial thrombosis with the distal part of common iliac vein was had partial thrombosis with the external iliac vein. And after which low molecular weight heparin was started. Gradually, the right lower limb swelling decreased, power improved, and the Doppler study, which showed that there were improving trends in the blood flow. Yes, sir.
Okay, I'll show the images.
Yes.
I think we have covered all this. So yeah. So CT was done initially, and on the CT, you can appreciate this large hypodensity in the left cerebral hemisphere, predominantly involving the entire left cerebral hemisphere. Subdural collection on the right side. Coming to the MR, what was the time interval signed, MR and CT?
3 days, sir. It was.
Okay.
Yeah.
Yeah, so we have restricted diffusion almost involving the entire left cerebral hemisphere, the basal ganglia, the central white matter, corresponding areas of low signal changes, slightly mixed pattern, but yeah, you can appreciate the low signal change on the ADC in the peripheral aspects. On FLAIR, you have obliteration of the sulci consistent with edema, also involving the brain nuclei. There is subdural collection on the right side. I do not have the source images, but on the MIP MRA images, the left ICA is not visualized, the MCA also is not visualized. Even on the neck, the left intercalateral artery is not visualized. So without the source images, I'm unable to tell if it's a vasculopathy or a vasculitis, but I think at least for a vasculitis, there would be some residual flow on the MIP images. Yeah, so I'll open the case for discussion. And what was the question, Sahil, regarding the case?
Sir, we wanted to find a cause, sir, which sickling, everything is negative in this child. Vasculitis, could it be a possibility here?
Good evening, Dr. Kapita here.
Good
So the main question here is whether it is occlusion of the ICA or is it like congenital, hypoplasia? Because the complete artery is not visible, the whole of the ICA.
Just a question, was a neck Doppler done?
The neck Doppler was not done. And only the lower limb Doppler was done when the child actually started having this DVT, the deep vein thrombosis features in one of the legs. And that was the same paralyzed leg. And that time then when we did the repeat Doppler, that time we did the neck Doppler, which showed, still very thin ICA. And they were not very sure about it, whether they're really seeing any flow in that. So ICA is still doubtful.
Without the source image, it's a little difficult, but if anyone wants to comment.
Send you the source images, no issues.
Yeah.
We'll send them. But how does it differentiate? How does it help?
The MIPS usually overcall the thing because it's a flow related thing. The MIPS, even there's minimal flow, it doesn't pick it up on the MIP images.
Okay.
The source images usually you can appreciate at least.
So this MRI was actually done outside.
Okay.
Yeah. So probably we may not be having, but we can ask for a CD and try to send it. Yeah.
Okay, we'll move on to our next case.
Yeah.
Sure. These are follow-up cases. I think the first one is again from Dr. Kavita. Fine.
Yes, sir. She was she's a 12-year-old female child. She was diagnosed as a case of SLE with juvenile dermatomyositis. So and she was started on steroid, mycophenolate, mofetil, and HCQ outside. So she presented with complaints of fever, cough, and cold since and weight loss was also there since 1 month. So considering tuberculosis, her HCQ and steroid was stopped outside by some clinician, and after which her skin lesions flared up, and after which she was admitted at our hospital for the further management. And on 26th of June, she had an episode of generalized tonic seizuring with uprolling of eyeballs, lasting for around 3 minutes, after which her consciousness deteriorated, and she was electively intubated, and she had, on examination, she was intubated with hypotonia, absent DTRs with bilateral plantas, which were showing flexus. So we did an MRI also as a part of workup. Yes.
Yeah. So the MR we discussed in the last meeting, we had changes of these subcortical cortical flare hyperintensities in the frontal parietal and occipital regions. Nothing on the diffusion, facilitated diffusion of the edematous changes in the subcortical and cortical regions. SWR did not demonstrate any mineralization or hemorrhage, but we had this vasculitis type pattern of enhancement, this cloud-like or fluffy pattern, predominantly involving the leptomeninges in the bilateral frontal, parietal, and occipital regions. So at that point, we thought came to consideration that this is actually a combined case of press and inflammatory vasculitis attributed to the SLE, a known diagnosis of SLE. So repeat scan was done, Sahil, and in the time interval, what was the patient's presentation then? Yeah.
So, sir, after which, in view of there was weight loss, there was fever, cough and cold since a month. So sputum for gene expert for tuberculosis, which was sent, which was positive. CSF studies, which were completely normal with sugar of 37, protein were high, sir, of 122, and TLC was 1. CSF gene expert for tuberculosis, which was negative. And ferritin were high levels, and LDH were low, and ADA was also not suggestive. So this child was started on anti-tubercular therapy, and considering her CNS lupus that is there, so she was started on immunomodulation therapy. And subsequently, the child developed neuropsychiatric symptoms like irrelevant talk with aggressive behavior. So repeat MRI was done later on.
Okay.
After 10 days.
So this is after 10 days of the initial scan.
Yes, sir. Second MRI.
Okay, so second MRI, we can again appreciate the subcortical white matter changes, but it has significantly come down as what we have seen in the previous study. Again, nothing on the diffusion to suggest any acute abnormalities. There is some degree of volume loss of the supratentorial brain parenchyma and some degree in the cerebellum. It's probably attributed to the medications. I did not have a contrast image to see the enhancement pattern, but at least on the MR images, the non-contrast images, the changes have come down in comparison to the initial study. Anything specific?
Yeah, actually, because she developed these neuropsychiatric manifestations later, so initial scans, we were not sure whether it is some vasculitis or lupus induced press itself. And later on, when the fever persisted, then we worked her up for tuberculosis, and that also came positive. So we were like kind of confused whether that vasculitis is because of tuberculosis or lupus. But she never had any basal exudates in the last scan, if you remember. So even in this scan, there is in fact improvements. So we are really not sure like how much weightage to give to that, whether there is any, the gene expert in the CSF is also negative. And is there any evidence of any CNS tuberculosis, at least radiologically?
On the non-contrast scans, no. At least on the second.
Okay, I think we have done a contrast, no, Sahil?
Yeah, but that didn't come through on the file.
Yes, ma'am. Actually, there was some issue with the zip file.
Okay.
Yes,
so
ma'am.
contrast did not show any specific, at least what we were told. Yeah, yeah.
Okay.
So what are the comments like regarding the lesions? Dr. Eugen, Dr. Kshitij, yeah.
It's a good case to show. I think we had a big discussion about press or not press last time. I remember with this one, and this was never typical in my head, at least. So it remains a diagnosis of exclusion, and when we call things press, we should think hard.
Sure, but it does fit under, it fits under vasculitis, Dr. Mankad?
Sorry?
It fits under vasculitis, see, I mean lupus vasculitis.
Yeah. What is vasculitis to a radiologist?
I know it's a pathological diagnosis, but
yeah.
No, but Keith, the cortical changes with the sweet changes, I think was more suspicious about vasculitis than press. No, when we talked, at least when we talked about it last time, in the context of a child with lupus.
That is true. I think that's what we were discussing, but I think the consensus was that this is consistent with press, and people had seen this pattern of nodular kind of budded appearance.
Yeah, but it's not as spot MRI diagnosis. I think in the context of a child with lupus that does have brain involvement, I think you can't ignore the whole history, you know, just looking at the scan, no?
That is true. Yeah.
So, Jael, the very fact that these lesions have completely disappeared in the next scan, does it favor a diagnosis of that these are more likely to be press related?
We'll have to see the contrast, I think, before we come to a conclusion.
Oh,
but the edematous changes have come down, yeah. Was he on steroids or what was the medication before the
Yeah, actually we pulsed her again,
yes,
because she was already on immunosuppression. 3 drugs were going on, but with this acute thing, then we again pulsed her with methylprednisolone.
Yes.
Yeah.
Okay.
I mean, and then later the tuberculosis thing also came up, so it's like right now very complicated.
Yeah. Okay.
Yeah. Okay. Thank you so much.
All right. Thank you. To our last 2 sets of cases, is Dr. Divyani is there? She can probably quickly run us through, or I can do it. Okay. In the interest of time, this was discussed last month. Not going into details of the clinical presentation, but this was a 14-year-old girl who had multiple falls of and loss of consciousness, was seizure-free, had seizures, and then had seizure-free interval for about 6 months. A year later, she had again presented with high-grade fever, seizures, altered sensorium, was mute, incontinent, and developed oromandibular automatisms. GCS was E2, V1, M3. The reflexes were brisk. Tone was increased in all 4 limbs. CSF did not demonstrate any abnormalities. The HS3 PCR was negative. MRI was done in April 22, and that demonstrated some areas of abnormalities in the white matter, periventricular, posterior periventricular white matter, also one in the bilateral middle cerebral peduncles. Temporal lobes also demonstrate these edematous changes. After the MR, the child was on anti-seizure medications. There was no improvement, and again, follow-up for ZNC and CBNAT for TB, fungal stain, and culture were negative. Autoimmune panel was negative. EEG demonstrated generalized delta slowing, generalized periodic discharges. There were no further clinical seizures, but there was no neurological improvement. Again, a repeat EEG demonstrated generalized delta slowing. MR and CT or MRI were done. Again, you can appreciate that this progressive abnormalities in comparison to the index scan, predominantly involving the white matter, but also deep brain involvement is also demonstrated. Some areas of brainstem edematous gene is also seen. Thalamic involvement is seen. Cerebellum was relatively spared, given the slices on the CT. Scan done a month later demonstrated the subcortical deep periventricular white matter cystic changes. And the white matter is almost slightly homogeneously hyperintense, slightly dirty appearance, what we normally see on a FLAIR scan. So again, predominant white and also gray matter involvement with the development of these cystic foci. DWI demonstrated some areas of restricted diffusion in the involved white matter. Contrast, there were some areas of incomplete and peripheral ring enhancing lesions. That time, we thought of a possibility of SSPE as one of the differentials. There were isolated case reports of temporal cysts in the subacute phase of SSPE. Other differentials were chronic encephalitis. Mitochondrial disorders were also considered as a possible differential. The child had a repeat measles antibody test done, and as for Dr. Divyani, the diagnosis was to be confirmed to be SSPE. So we have seen this case. If anyone has any comments, I don't think Dr. Divyani is there on the attending the session now.
Well, we had discussed SSP last time, but the clinical trajectory was not right. Is that correct from memory?
Yeah. So she sent the measles again for at Niman's, and at that time, this time it came out to be positive.
In fact, a lot of our SSP cases, I mean, wherever we suspect, I mean, till now we've never had any case where we've got it negative. I sometimes feel it is just a surrogate marker for any other maybe immune-mediated disorder. Just like your OCDs, you're just getting very high titers of anti-measles antibodies. Because I've not seen a single child where we have sent it and we've got it negative. The neuroimaging may not be really classical most of the times, and maybe we are just misdiagnosing a lot of these immune-mediated other disorders. Any comment on that?
Definitely doesn't look like an autoimmune encephalitis from all levels. Normally, actually, the hallmark of many of the autoimmune encephalitis is not only the fact that you get very little MRI changes acutely, but you get quite a lot of reversibility. You know, the inflammation resolve, you don't get that. So, I mean, I'm not sure this is
No, not in this case, but in general, is it just a non-specific marker as well for, just increased intrathecal synthesis?
The most, at least at Gosh, the few cases that we had, we don't see many. I think we had very few over the last few years. They normally get picked by the EEG neurophysiologist, because the EEG apparently pathognomonics, and he calls us and he said this is SSP. So I don't know. I feel like the EEG is very specific for SSP, at least from what our neurophysiologists are saying. So it may be interesting to look at your cases that are always raised and look at the EEG characteristic if they're also in keeping.
Yeah, sure.
All right, thank you. We'll move on to our last case. Okay, sorry, this second last. I think Dr. Rashmi is not there, so I'll probably just show the images. So this child had two scans at 2.5 months and 2 years 9 months. So on the initial scan, there was abnormalities of dysgeuria in the bilateral frontal lobes. The ventricle was abnormal. He had the dysmorphic basal ganglia appearance. Corpus callosum was thinned out and hypergenetic. Posterior fossa structures were relatively spared. They were initially sent for Prader-Willi syndrome. Clinical exome sequencing was sent, and once we saw these imaging findings, we suggested a possibility of tubulopathy. The diagnosis came out to be an uncertain significant variant of TUB B+, but I think given the imaging findings, we can confidently say that it is a disorder related to tubulinopathies.
I have a question for those interested in genetics here, and this is kind of increasing lots of the VUFS, which is the variant of unknown significance that you get. And when the imaging is so startlingly, obvious, at what level, because geneticists do not have a scaling system where MR imaging actually goes into escalation. They have a heat map system, I think it goes from red or whatever color. But at the moment they have an integrated imaging, but yet they want to scan all their children. Any thoughts on that? Because this should have been elevated straight away and it's still uncertain significance.
I agree with Kish. You need to do like a backward phenotyping to take all those children with and go backwards.
Yeah, even our own geneticists here, they're very not very keen on actually upscaling based on imaging, even if the phenotype is quite strong. And they say they were heat scale for it. And I thought we should probably write a piece on this, essentially, in Nihaal, titled Adding Fuel to Fire.
I think that's quite true, because recently we also had a case who clinically looked like Lee's only, and MRI was also, in fact, had a lactate peak also. Last time, I think it's shown that case here. And this child succumbed also last week, and still the exomes actually picked up Rett syndrome and some mitochondrial, this 2-3 kind of mutations. And clinically, it was looking more like a mitochondrial only with the Lee's kind of phenotype. So the geneticist thought first that because there is an acquired kind of a microcephaly, maybe it is fitting more in Rett's. But when the second attack came and the child actually became very disabled because of that, then that's when it was more, we were more confident about Lee's, and with the basal ganglia changes and so on. And so sometimes, yes, phenotyping, reverse phenotyping does help. And this child now has been diagnosed with the mitochondrial, I think, depletion syndrome. I'll present the genetic distinct in the next meeting.
Sure.
Yeah. Nice.
Thank you. Quickly, last case discussed in the last month, a 4-month child with developmental delay, frequent tonic seizures, had a sibling also with similar phenotype, if I'm not mistaken. But the previous MRI of the child was not available. Blood lactate, homocysteine, ammonia were normal. TMS and organic aciduria was awaited. As you can see, the parents had, almost eight children now, and they all presented with similar imaging clinical phenotype. On the imaging wise, we had the central areas of restricted diffusion in the posterior ligamental capsule, subthalamic nucleus, the midbrain, and also in the tracks along the pons and the medulla. At that time, and the T2 images, again, nothing very specific. Spectroscopy, there was no glycine peak, as a possibility of NKH was considered. We thought of an initial diagnosis of ITP encephalopathy based on the imaging findings. The only thing was the cerebral glycine was slightly elevated, and this was actually a paper from Dr. Vivek himself in one of his patients who had high cerebral glycine in case of ITP encephalopathy. So this is the genetic evaluation, and it came positive for ITP encephalopathy in the child and also in the parents. So this is just an example where the cerebral glycines can be elevated in ITP encephalopathy. Okay, if there are no further comments, I think that's our last case. Just on a somber note, I know this is predominantly an Indian diaspora, but this week we lost an international pioneer of neuroradiology, Dr. Sultan Patai. I had the opportunity of meeting him in Memphis and working on a project under him. Always a warm, approachable, great human being. So in the words of Longfellow, which is truly applicable for Dr. Patai, lives of great men all remind us we can make our lives sublime, and departing leave behind us footsteps on the sands of time. We thank Dr. Patai for all his contributions. We still reference his work on inborn errors of metabolism and brain tumors, and we'll probably miss him badly. If anyone wants to say anything, Dr. Mankad or Aidan, or anyone who has known Dr. Patai.
No, I think you have encapsulated that thought quite nicely on this final slide. And I think the big message is leave those footprints and those footsteps behind. It's important to create an impact because life is short and very unpredictable.
All right. Okay. Thank you, everyone.